recipient of the prestigious Courage in PAD Care Award for the Global PAD Impact Awards. As the president of the Vascular Institute of the Midwest, Dr. Dipple has been a tireless advocate for patients suffering from peripheral artery disease, or PAD. His unwavering commitment to improving patient care, challenging insurance denials, and advancing treatment options has made him a beacon of hope in the field of PAD. So join us as we delve into Dr. Dipple's journey, his fight for what's right, and his vision for the future of PAD care. Dr. Dipple, thank you for all you do to fight for life and limb for these patients suffering from one of the most debilitating diseases on this planet, peripheral artery disease, and its advanced stage, critical limb ischemia. Congratulations on this well-deserved award through the Global PAD Impact Awards, Courage in Care, which you definitely have.
Well, first of all, thank you. I think your praise is maybe I don't know, overwhelming, I guess. I don't know, but
Just
um,
speaking the truth.
well, I it's eh, I feel that there's a lot of patients out there that need services that for some reason we've vilified this whole kind of field, and I don't understand why, to be honest with you. And so it's I've never really looked at it as going out of my way to do what I think is right for people. I think that's just what we have to do as physicians and provide care to patients in need, and that's really the background of where things come from.
People can become doctors and they do a great job and they care for patients, but your passion is just exceptional and unwavering. And I'm curious where this stems from. Is this something that is just a character trait that you've had since you were a kid, or is there something that influenced this during your practice as a doctor?
Oh, yeah, there's probably truth to both of those. I'm sure if you'd asked my parents, I'm sure they would have told you I was quite a handful,
Well, I
um,
don't doubt that either.
um, but yeah, I mean, I've always felt strongly about certain convictions, um, and try and believe in doing what's right for people. And you know, I have so many people that come up to me and say, "I wish I could say the things that you say, but I just can't." And I'm like, "Well, say them." They're like, "Well, I can't." To me, I just say them. I mean, I've always said, I tell people what I think. I'll tell you whether I like your tie or your outfit. I don't really care if you wear it tomorrow or wear it the next day. It makes no difference to me if you throw it out, but I'm going to tell you what I think. And I think some people think that comes across the wrong way. I mean, I try and say what I think is right. I definitely am not always right, but I'm going to stand by what I believe in, and certainly am open to listening to other people's ideas about subjects. But
But here's what's different about when you speak of what's right, you're speaking from your heart, you're speaking from your experience. And it's not that you don't speak your mind and speak your heart and speak your experience to hurt other people. You do it with the right intention, that you have this unwavering commitment to patients and this passion that is incredibly contagious. You care so much about what you believe is truly right. You don't care if other people don't agree with you. It's just that you feel as though for the sake of the patient, for the sake of life and limb, you need to just say something or
yeah,
live in regret and let patients continue to suffer.
yeah, like said, it probably is a trait that I've had since I was younger. Um, and I don't really know where that comes from other than through my parents and how I was raised. I've always believed that you have to say what you think is right and what's true, and stand up for the things you believe in. And unfortunately, a lot of physicians nowadays are um, employed by big hospital organizations or big universities, academic places, and they're really kind of being suffocated in what they can say or can't say um, for the sake of being politically incorrect. And then they get threatened with their job and their livelihood and so forth. And I've never tried to go out of my way to be malicious towards people, but you have to say what you think is right and believe and stand by what you say is right. And that's kind of how I've always been. And so like I said, some people may not agree with the things I say or may not like the approach that I have, but I'm going to tell you whether I like your outfit or not, and what you do with it after that's your decision.
But what's great is that you truly stand by what you do in your practice, because when you do speak up, because I know that there have been individuals and organizations that have tried to instill fear in you, and it didn't work because you actually came out and said, I have a clean practice. I do what's in my heart. I do truly what I feel is right for these patients. And I care so much. So, bring it on. And I know for me, I really wish sometimes that I could, I didn't have to live in fear sometimes as a budding organization competing against the big boys and girls out there, that we have been threatened and warned as well to watch what we say and how we say it. And that becomes very frustrating, and that's why it means so much to me, and I know it means so much to many of your peers out there who can't speak out, that you've had this courage and care to speak up for the sake of the patient, for the sake of life and limb.
Well, I'm humbled by your words and I greatly appreciate, this award and this honor that you're bestowing. It's 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 meaningful to me and be acknowledged to that extent, but I guess I just I just do this because that's who I am. I don't know how to
Yeah.
describe it. I don't act like this, I guess, to win awards, but that I don't understand why we've vilified this problem for so long. I've said this for 25 years when I give lectures frequently. If grandpa walks to the mailbox and he has chest pain, we tell him to go to the emergency room. If grandpa walks to the mailbox and his legs get tired, we say you're just getting old. And that's how we treat people. And I don't understand it. And we've made it a crime to do procedures on people to try and alleviate their suffering. And that makes no sense to me. Um, if you've got people that are, you look at PAD for the most part, in general, it's a disease as people get older and at a time in their lives where they may be in their retirement age and they should be enjoying things, and yet they can't walk off their porch because their legs cramp up. And yet now we're being told we can't treat those people. And that doesn't make any sense to me. It never has made any sense to me. And we would never do that to a cancer patient. We would never, if a woman came into their doctor's office and said, they said, you have stage 1 breast cancer. And they say, well, okay, I want to be treated for that. And they say, no, you're not sick enough yet. You need to go home and wait till you're sicker, wait till you have stage 4 cancer, and then we'll treat you. Well, that's how we treat patients with PAD, and it makes no sense to me. Unfortunately, we live, the dogma of vascular disease is really, 50, 60, 70 years old. And some of it hasn't changed for decades. And it's a problem because um, therapies have evolved, techniques have evolved, medical devices have evolved, but yet a lot of people's thought process hasn't evolved. And a lot of people say, well, you need to do it this way because I said that's how you need to do it. And there's really no conscious thought that maybe we can do things better and less invasively and we can help people. And so, I've always said that there's only really two reasons why we treat people. One is to make them feel better, and two is to make them live long. But now you're telling me it's illegal or it's a crime to try and make people feel better. And I don't understand that. I never have.
And I think one of the things is the level one evidence for walking is medicine. But many of these patients that I'm dealing with, I keep getting, we have our free no cost to doctors, no cost to patients walking program. It's text based and it's app based. And I'm getting referrals for patients in their 80s to go out and walk and walk and walk and walk. And we have one of our PAD navigators on the this in the live studio audience today as well, and he'll attest to the fact, in the same way I will, to talking to these patients in the program. We had a couple calls this morning, and these poor patients in their 80s, they're being told that they have to walk through this pain. It's really tough on them. And one of them told me today, she says, Kim, I can only walk 4 to 5 minutes. And I said, so are you walking 4 to 5 minutes and then stopping and doing it again? She says, no, I can only walk 4 to 5 minutes and then I'm out of breath, my legs hurt, and I just am exhausted. I can't do it anymore. I just can't hold myself up with my legs. And yet they won't treat her. And we have to wait 3 months for insurance in the way it is right now. She has a Medicare Advantage plan. You're not surprised by this. We have to wait 3 months for her to get approved to have the doctor just go in with a kiss of the balloon. We don't need the roto-rooting devices or anything like that. That I know that that's a very contentious subject. Just a little kiss the balloon, slip the wire across the blockage and a little balloon and give that patient just a little bit of relief, right? Just enough blood flow to get them some symptom relief so they can get out and walk pain free, so that when it does close up, we know it does close up, it will, that they will have by that point grown a few more collateral vessels that they may not ever need a revolving door of treatments. They just need some initial relief, right?
Yeah, I mean it's we can all be Arnold Schwarzeneggers if we went to the gym 18 hours a day, right? But that's not how it's going to be. Some people just want to be able to walk to their mailbox. And so I get what you're saying. And it's, again, it gets back to it's a crime with how we've evolved to treat these people. To me, I'm not opposed to conservative treatment, and I do that, and I do think that it can help. And I do think that walking programs aren't a bad thing. But it's the same analogy in coronary artery disease. I mean, I can show you the same studies, the same results. Putting a stent in someone's coronary artery is going to make their chest pain go away a lot faster than telling them to walk 30 minutes a day until the chest pain stops. And so those studies have been done in the coronary arteries. Unfortunately, in the peripheral arteries, you know, you really are dealing with three different disciplines of physicians, and that's where you have the problem, because it's like three different religions, and it sounds strange, I think, to lay people that don't understand medicine. Um, but cardiologists, the only people that put stents in the heart are cardiologists. There's nobody else. And the thought process and the teaching and the history of cardiology is consistent. With legs, you're dealing with vascular surgeons, and you're dealing with interventional radiologists, and you're dealing with cardiologists, three different disciplines. And all three of them have a different thought process, a different teaching. And so it really is like arguing between Christianity and Judaism and Muslim. It's three different religions, and people sit there and yell at each other over whose God's better. It's going on in the Middle East right now. It's been going on for 2,000 years or more. It's not going to stop. And that's what we deal with peripheral artery disease. It's the same thing. It's arguing about religion and who thinks that their God is better than somebody else's God. And that's exactly where the problem lies. And and I was raised a certain religion, and I'm not trying to bring this into the conversation, but I believe in a certain God. That doesn't mean I'm gonna, criticize other people for believing in a different God. People can believe in whatever God they want to, but we should all get along and treat each other civilly. And that's what's happening now, is we're not. And that's where the problems lie, is that I think that we have too much disagreement between fighting factions, is really where I feel the problem is. And so I've just been vocal and standing up and saying, look, we can make people feel better by doing it this way. And, I'm not trying to change other people's religious beliefs, but, you know, you have to start somewhere of trying to convince other providers that what you're doing is not wrong.
We cannot alienate any practice right now because we have too many patients and we have too few practitioners. I have patients waiting literally for months to get in for a consult. I have some that literally for a first consult, if they're in the intermittent claudication stage, that they can wait 3 to 4 months before they're able to get in for an initial consult with a vascular specialist. And that's right here in the United States, it's some major hospitals. And so we really do need all hands on deck. And it's amazing that you're fighting for collaboration, across practices to say, hey, we've got to find some sort of common ground for the sake of these patients. Now, also, you've been very vocal about insurance companies, particularly Medicare Advantage programs impacting patient care. Can you share a specific instance where you've had to fight against insurance denials for PAD treatments? And I know you're going to say it's not just one, but start broad, but maybe share something specific that really has touched your heart.
Yeah, I mean it's insurance companies, again, this gets back to um controlling the narrative by the flow of money, right? And so there are advocates and there are opponents that are trying to, deal with the situation. And unfortunately, the insurance companies, for the lay people that don't completely understand how Medicare works, there's really four parts to Medicare. Medicare is a government insurance program, right? Medicare Part A is for inpatient visits. If you have go to the hospital and have your appendix taken out for whatever reason. Medicare B is really for outpatient stuff. Um, Medicare D is for prescription drugs. And then Medicare C is what people call privatized Medicare, and that's the Medicare Advantage programs. And it sounded, like a good idea to start with is Medicare basically said to private insurance companies, look, we will give you some money if you take these patients off our accounting books and you take care of them. And that's really what it kind of came down to. That's a 30,000-foot view. And so these private companies who have stockholders and they're for-profit companies looked at this as another way to make money, and they said, sure. And so they receive money from CMS, Medicare, and they receive money from patients through their premiums and stuff. But then the way they make money is they don't pay out. So it's like if you go to the grocery store and you fill up your grocery cart with groceries and you walk out the door and say, I'm going to take these groceries home and eat them because I'm hungry. And the grocery store says, we want our money. And you say, no, I'm not going to pay for it because I'm just not going to pay you for it. That's really how it works. That's really what happens to me. I mean, I hate to say it in this way, but I'm a private business owner. I mean, I practice by myself. I don't have a group. I don't belong to a university or a large hospital system. I practice by myself. And so it's no different than if I had a service where I changed the oil of your car or did anything like that. If you brought your car in and wanted me to change the oil and then you drove away and not paid me, I can't stay in business. But these Medicare Advantage programs, that's exactly what they do. I put a stent in someone and then they say, well, yeah, we're not going to pay you for that. And they say, why? Well, because we don't think they needed it. Well, the patient thought they needed it and their leg feels better and their leg didn't get amputated. And the Advantage company say, yeah, we just don't think they needed to get that. And so at that point, there's really not a whole lot you can do. I would say I have almost 3 full-time employees. That's all they do all day. That's all they do all day is fight with insurance companies. And again, I'm not saying this because I'm trying to get rich, but I'm trying to run a business. I've got employees to pay, I've got a rent to pay, I've got to buy the stents that I put in patients. And so it costs me money to run a business. And if I don't get paid for the services I provide, it becomes a problem. Now, to put this in perspective, United Healthcare, I'm going to throw them under the bus right away. They made a $23 billion profit last year in 2023. $23 billion profit. That's profit.
That's
That gets paid to their shareholders. That gets paid their 8-figure salary to their CEO and all the other levels of bureaucracy they have. And yet, if I want to put a stent in someone's leg to try and prevent it from being amputated, they won't pay me for it. And so this is a constant ongoing battle. This is a tremendous battle. And it's going on every single day. And it's difficult because patients end up getting stuck in the middle. Another big problem is trying to get pre-authorizations. Before you do a procedure on a patient, you have to get it pre-approved. That can take weeks sometimes. We have patients that come in with acute ulcer on their foot that need to have an angioplasty urgently. It may take 14 or more days to get it approved by the insurance company. In the meantime, their foot's just rotting and I can't really do anything about it. And then after I do get it pre-approved and then I do the procedure, there's probably about a 5 to 10% chance they're still not going to pay me. And so it's broken. The whole system's broken.
And Douglas has a question. Douglas, go ahead and unmute and ask Dr. Dipple, our Courage and Care Award winner, your question.
That that I think about that all the time, doctors. I don't really want a gynecologist telling me you can't save my leg. And how do you think what's it going to take to change this so that we can change that process and make it easier? How do we advance PAD where it's the same thing as when you say cancer or when you say heart attack? What's that process going to take?
I think there's a couple different ways that this will change over time. First of all, at a grass levels root, we just need to make people aware of how deadly PAD is. I think that's vitally important. I don't think that people understand that. I have patients that come into my office all the time and they have an ulcer on their foot. And if you look at the statistics, if you have a diabetic foot ulcer, you have a mortality of 50% at 5 years. 50% chance of dying at 5 years, which is extraordinarily high. And that hasn't changed much in 20 years, by the way. So people don't even understand how sick they are when they come in. They think that I just got an ulcer on my toe or I got an ulcer on my foot. But if they have cancer, and I say, you have cancer, they break down, they start crying, they get emotional. They shut down. They don't even realize what you're saying after that. It's such an emotional impact when they hear the cancer word. But you tell them they have an ulcer on their foot, and it's like, okay, we'll fix my foot. Your chance of dying of cancer is orders of magnitude lower than it is dying from a diabetic foot ulcer. So number one, I think we need a grassroots effort to make people help educate people so they understand how serious of a problem this is. Number two, Medicare is administered by Congress, and they are bound by the rules and the laws that Congress passes. And so I strongly feel that we need a grassroots effort to speak to our local lawmakers, senators, congressmen, etc., so they understand what the problem is and they can pass laws that will alleviate this situation. I think that's another crucial step. And then third, I hate to see it get to this point, but just in the past week, there was a medical group in Louisiana that practiced breast health medicine for women that had breast cancer and needed reconstructive surgery and so forth, that they got together and they sued their Medicare Blue Advantage provider in Louisiana, and they won a $400 million lawsuit. And so if companies start having to pay out $400 million lawsuits frequently, maybe they'll change their tune. So I think there's a number of ways that we can go about doing this, but I think that the bottom line is that people need to be educated what the problem is.
Yeah.
You know, the one thing about PAD is it's not curable. It's not curable. I mean, I can put a stent in someone and open up an artery, but I don't cure them of the problem that put that blockage there in the first place. You know, if your appendix gets bad and I take your appendix out, you're pretty much cured of what that problem was. You know, if you break your leg and you have to wear a cast for a few weeks and your leg heals up fine, you're pretty much cured of that problem. And a lot of times with cancer, you know, if you have many forms of cancer, you can be treated for that, whether they have to cut it out or give you chemo or give you radiation or whatnot, and you'll be cured of that type of cancer. It may not come back ever again. But PAD, you're not cured of it. And so I think too many people think that it's something that's a one and done thing. And it's not. It's not something like I just put a stent in someone and you're cured forever. It requires maintenance. It requires medications to keep diabetes under control, to keep your cholesterol down, to keep your blood pressure under control. You need to stay on your walking program. All that kind of stuff is important. And too many people just think, well, you know, you put one stent in, you're cured. And then if I put in a second or third or fourth stent, well, then I'm just doing that to make money because I'm a greedy doctor. And that's entirely not the case. That's entirely not the case. It's a progressive disease that unfortunately requires maintenance every once in a while. And you got to go back in and put another stent in.
You've participated in the production of Amputation Nation. It's a documentary about PAD and CLI that is being worked on. We've had a couple of short clips released to preempt that film. What do you hope that this film will achieve in terms of public awareness that you were talking about, as well as policy change as well? Because so far, the clips that are out there are incredibly powerful.
Yeah, again, I think it gets back to the you know, the education level of understanding, you know, and one of the patients that I shared in that documentary is one of the first patients I ever took care of when I finished my training. I was 3 weeks out of my training and I was in private practice, and this was in August of 2000. And I had a patient come into my office, and he had had a third bypass surgery 30 days earlier, and the bypass graft had already closed. And he basically had no flow into his leg, and he was in excruciating pain, couldn't sleep at night. And the surgeon told him that they couldn't do any more bypasses on him, and they had to amputate his leg above his knee. And I was about as green as you could be. I mean, I was fresh out of my training, and I was just staring at him like, well, I don't know if I can do anything to help you, but if they're going to put your leg in the trash can, I can't make it a whole lot worse than that. So I brought him in the cath lab the first day, and I worked on him for about 4 hours, and didn't make a whole lot of progress, but thought maybe I could do a little more the next day. So put a catheter in his leg to try and dissolve some of the blood clot that was in there, and had him sit in the intensive care unit overnight, and had him come back the next day and next to the cath lab, and didn't look a whole lot better. And I worked on him another 3 or 4 hours, and still wasn't making a whole lot of progress, and was kind of starting to feel a little dejected. And I thought, well, I'm going to try one more thing. And so I put the catheter back in him one more time, and had him come back the next day. And I took a picture, and, you know, kind of miraculously, he had unbelievably great blood flow down his leg. And I was shocked. And I was like, wow, that turned out pretty good. And his leg felt better immediately. And and then over the next 3 or 4 years, that guy came back to my office multiple times, and his stents had blocked off again. And I brought him back in, and I unblocked his stents, and I must have done 15 procedures on him. He would call me up and say, my leg hurts again. I'd say, come on back in. I'd fix him, send him home. I learned so much from him personally just because of all the things I had to do to try and keep his leg attached. And he went from he was in his late 50s, he was around 58 years old, and he went from being disabled to working again. And his job was he was a gas meter. He would check the gas meters. He would read the meters and walk house to house to house and check gas meters on people's houses. And so he went back to being employed. And he came to me one day after about 3 or 4 years, and he said, Dr. Dipple, I appreciate everything you've done for me, but my insurance told me that I've reached my lifetime cap and I can't come back and see you anymore. And he goes, I have to go to the VA. And I said, well, it's been a pleasure taking care of you, Larry. And if you ever want to come back and see me, I'm happy to take care of you again. Within 6 months, they'd cut off his leg, and within 6 months, he was dead. And that he was probably about 62 years old. And I've always been convinced that he would have probably lived many, many more years if he had had both legs attached. And that was one of the very first patients I ever took care of out of my training. And I've never forgotten him. And I mean, that's, you talked about where some of the passion comes from. It's like you see what you can do to help people, and you see what the results are if you don't help people. And so, that's kind of, that those kind of things drive me every day.
Wow, that's amazing. And it's amazing though that you gave him the open door, that you would treat him. And I think the fear that it wouldn't be covered and not wanting to ask you to do a procedure that was not covered led him to settle for amputation. And that is so sad that with our federal government, that is the VA, our federal government would not allow this patient. You've saved his leg and saved his leg. You have proof that you have saved his leg. There's evidence. Why is it that they did not allow him an external second opinion from someone that has proven that they could keep him on his feet and working full time? It blows my mind, and it's disheartening.
I mean, it's not an uncommon thing sometimes, stories like that. I mean, it's, I why the insurance companies make those decisions. Again, it gets down to, you know, trying to save money somewhere. And it's like, how do you value a human life or a human leg? I mean, to me, the statistics are, to me, it's still staggering when you think about, if you have a person that's over 60 years old and you amputate their leg, their mortality rate at 1 year is almost 30%, which is extraordinarily high. It's unbelievably high. When you look at the mortality rate of breast cancer at 5 years is about 15%, 1.5 versus 30% at 1 year if you have your leg amputated. And so it's extraordinarily high mortality rate. Maybe that's why they do that, because if they don't have any more people to pay off insurance, then they don't have to worry about it.
Yep, exactly. It just is amazing. Well, I think one of the things is, and I hate to put it this way, but breast cancer is sexier than PAD.
There's no question. I
And
mean, if you ask every woman in this country, what are they afraid of dying of? It's breast cancer. And I get that because, and if you turn on any football game on in October, you're going to see pink ribbons all over the place because there's breast cancer awareness. And I get that. September's PAD awareness month, but you don't see ribbons at football games to celebrate PAD. And yet when you look at the statistics, and I'm not trying to minimize breast cancer, it's a deadly disease, it's terrible.
it's awful. Yeah.
1 out of 8 women get breast cancer. 1 out of 25 women die from breast cancer. 1 out of 3 women die from heart disease, and that includes vascular disease. You have an 8 times more likelihood of dying as a woman from vascular disease than you do of breast cancer. And yet women are terrified of breast cancer. I get it. It's an emotional thing. But your chance of surviving breast cancer is way, way higher than it is of surviving vascular disease. Those are the numbers. And I'm not trying to minimize what breast cancer is. It's terrible. But I can't get people to understand that PAD is worse. That's the problem. I mean,
And more
PAD,
prevalent.
and if people just understood that, that would be great. Just understanding that it's a worse prognosis and that we need to do more to treat it.
And in this process, you've been critical of some academic perspectives on PAD treatments. And how do you balance evidence-based medicine with real-world clinical experience in your practice? And I would imagine that with the case that you just had mentioned moments ago, that came into play as well, which is why you were able to continue to keep this man on his feet and just, do a revolving door of treatments versus the VA that ended up just going straight to cutting off his leg.
Yeah, I mean, in medicine, as much as you want, medicine is always been a combination of art and science. I mean, it's not a black and white discipline. There's a lot of gray zones in there, and there has to be at least some common sense somewhere to extrapolate what we know versus what we think it should be, and how we can bridge that gap between what is factual and what we think is optimal maybe. There in order to do pure science, and I mean pure science, going back to how penicillin was discovered and realized that can cure pneumonia, or how the polio vaccine came about. If you go back to pure science, you have to fix all the variables except one, and then you give them a placebo or a non-placebo, and you see if the placebo or the non-placebo makes a difference. The more complicated the situation gets, the more variables there become, and it's harder to control all the variables sometimes. And that's where it gets to be difficult to do pure science for some of these disciplines. For cancer, it's easy. You have stage X of cancer Y, and if we treat you with cocktail A, B, and C, is that better than cocktail X, Y, and Z? So there's a lot more things you can control. In PAD, there's too many variables that are uncontrollable, and it makes it harder to do pure science. And so at some point you have to extrapolate from what you know to what you don't know, and make a leap of faith that it's going to work. And then that comes down to your experience. If you do something 1,000 times and it works 999, then it's probably going to be good for somebody.
And how often, I mean, one of the freedoms that doctors have is to use a lot of these products off label. And I think that and then you can actually create the evidence going forward. But how do you create evidence? I have so many doctors that will say to me, "Well, show me the evidence." And it's my biggest frustration in this whole thing is they gaslight me. Yes, I'm using that term. They gaslight me by asking me, "Well, where's the evidence?" Well, my response is, "Well, why don't you? You're a practicing practitioner. Why aren't you helping to create the evidence? Why instead are you arguing for your own limitations versus actually practicing medicine?"
I think that's a great point. I mean, I think that there are some people that are comfortable in their own bubble and comfortable with the dogma that they have been taught, and maybe believe that things are as good as they're going to get. And there are other people, I think, that want to push the boundaries of of therapy and try things. I mean, there's been plenty of things I've tried that haven't worked. And I, but I think if you're afraid to try, you don't know if you're going to find something that works. And I think that's part of it too, is that I never go in with an intention to try and harm people, but sometimes you go in there with the intention that I hope this works, but I'm not sure if it's gonna, because you're out on the edge of where what we know of is capable. Like this guy that I explained to you earlier. I mean, I tried a number of different techniques on him, and I didn't know if any of them were going to work. And then I was amazed that it worked. Now you could say that's an N of one, and that's not science, but it helped me develop my algorithm for how I treat patients. You know, if you're going to throw someone's leg in the trash can, I don't know why you would be afraid to try and fail. You know, you can't be afraid to fail in what you do.
Nope. I mean, I think patients would agree as well. Heinz, do you have a question on this subject? Go ahead and unmute and ask Dr. Dipple, our Courage and Care Award winner, your question.
Hi, Doctor. Thanks for joining today. You spoke about this a lot today about, broken-legged heels and then cancer, a lot on cancer, breast cancer. There's lymphoma, stomach, had leg cancer, by the way. Nothing to tack onto that, though. You get radiation chemotherapy, that leads to CAD and PAD.
Yeah, yeah.
How many doctors tell their patients, by the way, you might get blocked arteries due to this radiation or chemo, and your mortality rate then goes from 5 to 1, maybe to 3 to 1, or 1 in 3, would you know, do doctors actually tell the patients that you're going to have some side effects? Oh, and by the way, you might get clogged arteries.
Yeah, unfortunately, probably those don't always get conveyed because again, patients think they're going to die from cancer, and so they're kind of willing to undergo whatever treatment's necessary to save their life, and then unintended consequences of some of those treatments. And so, I mean, the classic example is head and neck cancer, right? So when you radiate someone's neck for throat cancer, it makes it extremely difficult then to operate on a neck if you have blocked artery in the carotid arteries that could cause a stroke. And so, we've found better ways to do that. And so putting a stent in there is a better option than doing surgery for that situation. But you're right. I mean, there's always going to be unintended consequences. I mean, patients that have had radiation to their chest for certain lymphomas are prone to developing accelerated coronary artery disease 20 years down the road. So if you're a teenager or, and you have lymphoma, by the time you're in your 30s or 40s, you may have very severe coronary artery disease from that radiation exposure. So yeah, I mean, your point is well taken. And again, it gets back to kind of what I said earlier is that we don't intend to harm people in things we do, but there are unintended consequences sometimes. And you kind of have to, I've always had the mentality that you have to kind of cross that bridge when you get to it. And if you're afraid of causing a bad outcome, then don't apply the therapy. And so if you're afraid of causing, coronary artery disease in someone down the road, then don't radiate them for cancer. Well, then they're going to die from their cancer. And so it becomes a circular argument.
But it's one of those things that what you're trying to do is give them another day to walk and another, to spend time with their kids. It's just giving them another day to live. And you're just kicking the can forward, kicking the can forward. And so you got to deal with what's in front of you, right? In that moment. And you can't worry as much about the consequences if you're just trying to save their life. And I think that it's the same thing with their limb.
Yeah, I mean, no, if you look at the big picture, nobody has survived life yet. Okay. I mean, we've all got a limited amount of time on this planet and we're all going to die at some point. And you want it to be quality of life and you want it to be longevity, right? And so again, it gets back to what I said. If you can make people feel better and live longer, that's really what the goals of medicine are. And so if you're afraid to deliver a therapy to someone because you think that they're going to have a bad outcome or a negative consequence, then withholding that therapy may make their quality of life to the point where they don't want to live anymore. And so you're essentially doing them a disservice. There's a story that was told to me in medical school, and it kind of goes something like this. It was one of the professors who was giving a lecture. If a patient comes in with severe motor vehicle trauma, and they have 100% chance of dying if you don't operate on them, And if you operate on them, they have a 90% chance of dying. Okay. Would you operate on them? And then you compare that to a doctor that say is maybe a primary care doctor, and he doesn't prescribe an aspirin to a patient to prevent heart attacks and strokes. And 6 months later, the patient dies from a heart attack. Which doctor is more likely liable for that patient's death? The trauma surgeon that knew there was going to be a 90% mortality, or the primary care doctor that never prescribed a baby aspirin? And so you have to think about what are the risks and benefits of what you're doing. But if you have a fear of what you're doing, then maybe you shouldn't be in that specialty in the first place. But again, I'm not trying to hurt people, but there is a risk in what I do. I walk on a tightrope every single day without a safety net. And I've had patients that have had bad outcomes. But if you don't get back up on the horse and keep riding it, then I become paralyzed in doing my job. And so you just have to keep going.
But at least, your intention is pure and you're really trying to do what's right for the patient and you're honoring what they desire. And you make sure beforehand, because we have several mutual patients, you're a very good communicator of the risk and reward with any procedure. And you are a big proponent of conservative therapy. And for those who are watching, they may think that you're all about procedures, but that is certainly not the case, because we have quite a few mutual patients that have been, told that they do need to walk, walk, walk. So I want to make sure that that's very, very clear. And they've been put on the very regimented conservative therapy programs through Dr. Dipple before anything was performed interventionally. I want to turn it over to Kim. Kim has a question about something that we were talking about earlier, which is the mortality rate of these amputations. Kim, go ahead and unmute and ask Dr. Dipple your question.
Yes, I was just curious. The people that have amputations that tend to die shortly after, is that due to complications or is it due to their mental health?
Yeah, I think it's all of the above. Just just in the operative mortality alone, these people in generally are sick, and so you're operating on unhealthy people, so their chance of dying within 30 days is high. Just getting out of the hospital, most of them end up in a nursing home for at least a short period of time. Many of them never walk again. Less than 50% ever have a prosthesis and they ever stand again. And so then you end up with, pressure ulcers, pneumonia, other complications, blood clots in their legs. So it's a combination of all that. But the mental health is certainly an unrecognized part of that, I believe, or underappreciated part, where a lot of people kind of feel they've lost their body image, they've lost their mindset, they become depressed. And so I think that does play a role in it to some extent.
Thank you. And Douglas has another question. Douglas, go ahead and unmute.
Too quick. Number one, you're right. I'd rather drive 5 hours to see you once a year and keep both my legs. That's as a patient, that's for sure. But thinking about the cancer thing, if you go back 30 years, I wonder what some of those patients went through with the cancer experimentation to get where they are today in saving those lives. Did that make sense? And where we are today with PAD and where we're going with the technology and all the things that are coming out now in 5 years from now, 10 years from now, where will we be? Because 30 years ago, how many people looked at a doctor doing breast cancer surgery and saying, "What are you doing?" Because they didn't know what they know today.
Right. Right. I mean, it was Richard Nixon that said we're going to cure cancer, and that was 50 years ago. So we've definitely come a long ways. There's been a lot of resources poured into that. And to your point, and I've said this many times before, if you look at all the disciplines in medicine, I mean, every subspecialty you can think of, the two disciplines that have the most randomized clinical trials, the most studied fields are oncology and cardiology, hands down by far, not even close. There are multiple studies in cancer treatments for all different kinds of cancers, all different stages. And when you look at cardiology, when you look at treatments for heart attacks and cholesterol and blood pressure and heart failure and irregular heartbeats and pacemakers and so forth, there have been thousands and thousands of studies done. As a cardiologist, I'm aware of the data. But when you try and translate that into the vascular space, other disciplines that aren't trained in cardiology per se are not as aware of some of that literature. And that's where the discrepancy comes. That's where the gap comes between different disciplines in treating PAD. And I'm not here to say that only cardiologists should treat PAD, but some of the literature that has been used for coronary artery treatment extrapolates well into peripheral artery treatment. And if you're not familiar with that literature, then it makes it a little harder to have that leap of faith, I guess, is what I would say.
Yeah, and I think that, when it comes to cardiology, you do have a lot of data, and especially when it comes to all of the different blood thinners and antiplatelet anticoagulation therapy. But no one has taken the time to translate that into the legs. I know that we had the Voyager trial with Xarelto that said it can be effective in the legs, but do we really know how much for every single different patient and how long? And Dr. Oneida Dubois out of Mass General brought up a really good point over the past year, and she's gone to several different conferences where she's talked about the fact that these patients are not getting the adequate amount. You have Coumadin and you have warfarin that we're constantly measuring, and we adjust the dosage. Why are we not doing the same for these other patients with PAD? Because obviously, in so many of these patients, there is a revolving door of treatment, because it seems that the current dosages are not quite working for every single patient.
Yeah.
And so we do need people to focus on new research in these specific areas for PAD in particular. Right?
Yeah, I mean, to put that in perspective, again, it goes back to what I was saying, is that the literature for anticoagulation with stents goes back to the 1990s in the coronary world. The Voyager trial that just came out a couple years ago was the first trial of its kind for the PAD world. And that's not uncommon. The PAD literature is conservatively 15 years behind the heart literature, the cardiology literature. And so the Voyager trial specifically came from out of the coronary world, because people who had coronary stents were being put on antiplatelet drugs, but then they also had irregular heartbeats like atrial fibrillation, which requires a different type of blood thinner. And so the question arises is, how do you use these in combination so that they're safe? And so there's been dozens and dozens of studies done in the cardiology world with different types of different combinations and doses of anticoagulants. Those studies have never been done in the peripheral world. And that's, again, it gets back to extrapolating data that's available from another discipline and applying that to the peripheral world and saying, well, it makes sense over here and it's been proven over here. It should work over here. And quite frankly, we're never going to have a company drop $100 million to prove it. And that's what it takes to run these studies.
It's something that we're very passionate about, and something that we push with our patients, that every patient, I don't care what other discipline that is treating your PAD, we're practice agnostic. What we care about is, though, that for every patient that does have PAD, no matter the practice, that they do need a referral to a cardiologist. And we always suggest an interventional cardiologist, but because we want them to get their medication managed. So many doctors want a primary care physician to be the one managing the medicine. And I don't think that the primary care physician should be the one offering as front line the medications for PAD. And I don't think that it should be that if they do get diagnosed by the primary care physician for PAD, that they don't get referred until they reach a toe stub away from amputation. And there is, in a lot of places in the world, that is the case. And I was surprised to see that being the case as well in some hospitals here in the US as well. Every single patient diagnosed with PAD needs to see a cardiologist for proper medicine management. And I know that there are actual vascular medicine doctors that simply specialize in that. That's fine. Then get them to a vascular medicine doctor, but it needs to be a referral for one or even both, because even still, 3 in 5 people who suffer a heart attack have PAD. And I don't understand. I don't care if a patient doesn't have symptoms yet. You need to have that referral to the cardiologist no matter what, because it's inevitable they will need them. And you need to have some sort of baseline established for these patients and relationship established with a cardiologist. And I
Yeah.
see you nodding.
Well, it gets back to the point that I made a little earlier, is that putting a stent in anybody does not cure them of the problem. This disease is not curable and it needs to be managed. Just the same way diabetes is not curable, but you manage it with medications, and you manage high blood pressure, and you manage high cholesterol. Those are not curable diseases. The primary care doctors, unfortunately, in the United States are overwhelmed, and so a lot of those things kind of maybe don't always get the attention that they need. And so I think when you're seeing a specialist that deals in vascular disease, it makes sense that they should also be managing those medical problems and managing their cholesterol and things like that.
2 more questions for you. I really appreciate your time. These are for 2 special series that we have. One is called The Journey to Diagnosis, because one of the things that I'm really passionate about and the Global PAD Association is passionate about is really how do we get these patients to their doctors sooner? How do we get physicians inspired, primary care physicians inspired to actually start diagnosing sooner? And on the one hand, we did an entire conference called Save My Piggies, where the patients shared their journey to diagnosis. That didn't work. So what we're trying now is kind of on the opposite end, is getting the doctors to share the horror stories of a patient that represents a large number of patients that should have been diagnosed sooner. They weren't, and you can't figure out why this patient fell through the cracks. So if you have a story that's representative of the real problem, that would be amazing. Why we need to get that ARC Act passed and why we need these doctors to diagnose PAD sooner.
Yeah. I mean, my assumption is that everybody has it. And so to me, if you've ever eaten at McDonald's, you have CAD and you have PAD. There's no question in my mind. And we can talk science and data, and I could show you that data as well, but it's a disease of aging. It's a disease of the society that we live in. And so to think that people don't have it, to me, is mind-boggling. Everybody has it.
And do you have a story of a patient that may have gotten had, a hip replacement or spinal fusion, that their symptoms were not relieved by those big procedures, and all they needed was a PAD diagnosis and a quick intervention with the kiss of a balloon?
Um, yeah, I think that there, I say this frequently to my patients. There are 3 main reasons why people have leg pain. There's circulation issues, which is a plumbing problem. There's muscle and bone problems, which is more of your carpentry, construction problems. And then there's nerve problems like neuropathy and stuff, and that's your electrical problems. And you can have all of the above. You can have arthritis in your joints, and you can have sciatica, and you can have clogged arteries. And so they're not mutually exclusive. And so a lot of times you got to talk to the patients, ask them what their symptoms are caused by, what reproduces them, what makes them feel better. A lot of times you can make a diagnosis just talking to the patients. And sometimes patients have multiple causes. You can have sciatica pain and you can have PAD. And I can put a stent in your leg and it may make it feel a little bit better, but you need to have your back operated on to make it feel better as well. So there's a lot of overlap in symptoms sometimes. That's where it becomes a little difficult unless you really sit down and spend a lot of time talking to the patients, say what makes it better, what makes it worse. And then you can use some testing to kind of confirm that. but it's not always a straightforward question and a straightforward answer. And so definitely see patients that, they've had their hip replaced and they still have pain, and you put a stent on them, they say, oh, my pain's gone. That doesn't mean they didn't have arthritis, they didn't need to have their hip replaced, but they might have had two problems going on at the same time.
You bring up a couple really good points there. That we had Dr. Lorenzo Petrone, an interventional radiologist who was in London, now in Italy, and he came on and he said one of his key questions when it comes to CLI is he always asks the patient, okay, you do have pain that wakes you up at night. How do you resolve that pain? How do you relieve that pain? And if the patient says, well, I just sit and I rub my feet and then I'm able to kind of go back to sleep and kind of, stretch. Okay, well, maybe that's not CLI. Maybe that's something else. But if you are actually saying, because I know every one of my patients that's in CLI will tell you intuitively what they do is they hang their legs over the side of the bed and they shake them first. And if that doesn't work, they get up and they walk. And that tends to help because it's all about that gravity. It's helping a little bit more blood flow to give them a relief. So really good points there. It is, I always say that if you ask the right question, you get the right answer, right? One more question. Oh, did you want to respond to that? The next question, this is our final one. I know you got to get back to save some piggies. This one is one of my favorite questions. It's near and dear to my heart because when I worked at Forbes magazine and I was interviewing executives of some of the top Fortune, 500 companies, I always wanted to know what was the 10 minutes that really mattered in your career? What was that catalyst for some amazing change in your life, in your career? And for us, this is sponsored by Reflow Medical, and we're calling it the 6 minutes that mattered because it's how long that you're going to need that to have that balloon inflated and before you bring it down in order to save those piggies. So we're calling it the 6 minutes that matter. What was that defining moment in your career?
Oh, you know, I I don't know if I have one 6 minute moment, but you know, I don't share this a lot with people, but my dad was a cardiothoracic surgeon, and I grew up in the medical field, and ever since I was young, I mean, first grade, I wanted to be a cardiologist. That's all I ever wanted to be. I mean, I brought artificial heart valves to show and tell one day when I was in grade school. I mean, who does that as a kid, right? Um, and I grew up wanting to be a cardiologist. And then when I did my fellowship, I had the pleasure of working with a number of great guys. Dean Kiriakis was one guy, and Tom Shimshak, who trained me to do peripheral stuff. And at the time, I'd never had any real knowledge of doing endovascular stuff or peripheral stuff, but I was fascinated by it right away, just because you had to think a lot. It was back when I was training, it was still rather crude in the tools that we had, and you were constantly trying to um, make a round peg fit in a square hole, and how you were going to get catheter from point A to point B and do the job. And so I was intrigued by the problem solving aspect of things. And I mean, now things have gotten a lot easier. The catheters are a little more refined. It's not quite as maybe as challenging and stuff, but that was one of the things that kind of opened my eyes to the whole peripheral world when I had only had blinders on to the cardiology world, I guess.
Thank you. Dr. Eric Dipple, a true inspiration, the recipient of the prestigious the Courage in Pad Care Award at the Global PAD Impact Awards. He is the president of the Vascular Institute of the Midwest in Iowa. We really appreciate you. This is an award that truly is near and dear to me because this is the only one that was, well, there were two of them, Patient Champion. And this one were actually truly voted on by the patients. And so when you think what you're posting on LinkedIn, which is a business social media site, that you're just reaching your peers, you're just reaching your industry. In fact, this particular award goes to show that there are quite a few patients that are listening. And they're the ones that, as much as I was paying attention to you, that when we put out this award, I was getting those responses from people that are patients, people with PAD, people suffering from the most advanced stage of CLI, PAD, which is CLI. They're on there and they're telling me, hey, you got to take a look at this guy's posts. He's really speaking up and fighting for life and limb for these patients. And for that, Dr. Eric Dipple, we really appreciate all you are doing, not only in your clinic, but through social media and other channels to save and fight for life and limb.